Hello everyone. Today I'll be presenting my paper on prevalence of optical coherence tomography detected diabetic macular edema in patients with diabetic retinopathy. I am Dr. Siddharth Sani, a PG resident from Medical College Ahmednagar. I'll be presenting this paper to you co-authored by Dr. Anil Kumar Singh. Starting with the background and objectives, diabetic macular edema is the most common cause of reduced visual acuity in diabetics. The number of diabetics are predicted to rise to 109 million cases in India by 2035 from the current approximate of 65.1 million. DME is defined as a retinal thickening at or within 1 disc diameter of center of macula. The onset and progression of diabetic maculopathy majorly depends on the duration of diabetes mellitus and the stage of diabetic retinopathy. DME is detected clinically only after its visual status damaging characteristic features are noted. OCT is a non-invasive imaging technique that provides high-resolution cross-sectional images of the macula, which help in the early detection of diabetic macular edema, hence the advent of OCT. The first aim of the study was to study the prevalence of DME using OCT in patients with diabetic retinopathy, and the secondary objectives were to study the distribution of cases as per stage of DR and the percentage of DME in patients depending on duration of diabetes mellitus. The study design was a hospital-based observational descriptive cross-sectional study. It was undertaken from September 2019 to January 2020. 130 cases of diabetic retinopathy were visiting ophthalmology OPD of our tertiary care hospital, and those with DR admitted in other departments of the hospital were selected. The sample size was calculated from OpenEPI version 3. Statistical analysis was done by descriptive statistics. Chi-square test was applied to test association between variables and groups. Probability of p less than 0.05 was considered as significant, and SysStat software was used to analyze the data. Inclusion criteria were diabetics visiting ophthalmology OPD with signs of diabetic retinopathy, patients admitted in other departments with signs of DR, and those willing to consent for the study. Patients with hazy media due to corneal ulcers, dense cataracts, corneal opacities, uveitis, and vitreous opacities were excluded. So were those with macular degeneration independently causing diminution of vision. Macular edema due to any other cause and non-diabetic patients with macular edema were also excluded. Those fulfilling the criteria would explain the OCT procedure, their consent was recorded, pupils were dilated before OCT with dilating eye drops, and central macular thickness was noted from the final OCT report. A detailed history of diabetes mellitus and the treatment being taken for it was recorded. Visual acuity was recorded and anterior segment examination was done on slit lamp. Fundus examination was done with the help of indirect ophthalmoscope and on slit lamp with requisite lenses. DME was evaluated in DR patients with the help of OCT. A central retinal thickness of 250 plus minus 25 micrometers was considered as normal. Anything above it was considered DME. The median central retinal thickness of 250 micrometers was taken as a reference from a systematic review done by Virgili G and others. Ethical concerns were taken care of as OCT cost was not borne by the patients. Starting with the observation results, 57.69% or 75 cases were males, whereas 42.31% cases or 55 were females. 38 cases had OCT proven DME, while 92 cases did not. Therefore, the prevalence of OCT proven DME in patients with DR was calculated to be 29.23%. Of the 130 cases in the study, 124 cases or 95% belong to the non-proliferative stage, whereas 6 cases or 5% belong to the proliferative stage. Upon correlating the duration of diabetes mellitus with OCT proven DME, it was found that maximum patients with diabetic macular edema were in the first 5 years of the onset of diabetes mellitus. 22 cases fell in the bracket of 0 to 5 years. Coming to the discussion, diabetes mellitus is known to cause microvascular angiopathy leading to end organ damage. In this case, the eye. Edema is primarily caused by breakdown of inner blood retinal barrier at the level of retinal capillary endothelium, allowing leakage of fluid and plasma constituents in surrounding retina. Diffuse macular edema is caused by extensive capillary leakage and localized edema by focal leakage from microaneurysms. DME is detected clinically only after its visually disabling features are noted. It is possible to prevent this by OCT evaluation as it detects DME in early stages. Davis and others studied the prevalence of DME in patients with DR and found mean age to be 59 years, which is similar to our study. Akandi and others found prevalence of DME to be 15.3% of total 63 cases of DR, which is less than our study. Davis and others found 28 cases of NPDR and 35 cases of PDR. LOLP and others found that DME increases with duration of DM and prevalence is 5% within the first year, 5 years and 15% at 5 years. However, our study has shown higher prevalence in the first 5 years of the onset of diabetes mellitus. Upon conclusion, we find that prevalence of OCT-proven DME in cases with diabetic retinopathy is 29.23%. Of the total cases studied, the stage-wise distribution was higher on the non-proliferative side, and higher prevalence was seen in those with a duration of up to 5 years of the onset of diabetes mellitus. Thank you for your attention. Hope the presentation was lucid and informative to you. Thank you.